The following podcast is part of a certified educational activity titled Strategies for Appropriate Assessment and Use of APOE Status in Alzheimer's Disease, Clinical Care in the United States. Access the entire activity and complete the post-test at peerview.com/JNT860. Downloadable slides and practice aids are also available.
Hi, and thanks for joining us for our program today on strategies for appropriate assessment and use of APOE status in Alzheimer's disease clinical care in the United States. My name's Eric Music. I'm a professor of neurology and a clinician in the Memory Diagnostic Center at Washington University in St. Louis. And I'm pleased to be joined by my colleague, Dr. Sharon Shaw, who's a clinical professor and chief of Memory Disorders Division in the Department of Neurology at Stanford University. Hi, Sharon.
Hi, so happy to be here.
Me too. So let's talk about our goals for today. So during this presentation, there's three major goals. The first of which is to understand APOE genotype and how it influences Alzheimer's disease risk, clinical course, and how it has important safety implications for patients who are receiving anti-amyloid therapies. The second goal is to understand the successful use of APOE genetic testing in clinical practice, and understanding how this depends on identifying appropriate patients, ordering the appropriate tests, and interpreting the tests appropriately. And finally, we'll talk about shared decision-making with patients and care partners to guide and informed decisions about APOE testing as a key component for Alzheimer's disease care planning. So let's get started first by understanding the clinical relevance of APOE genotype status. So apolipoprotein E, which is encoded by the APOE gene, is a multifunctional protein that's involved in lipid transport, both in the brain and in the periphery. And it has a multitude of different functions, but it has been closely tied to the clearance and degradation of amyloid beta protein in Alzheimer's disease. So the APOE gene in humans has three common alleles, the epsilon 2, epsilon 3, and epsilon 4 alleles, which encode APOE2, APOE3, and APOE4 proteins. We'll just call them APOE3, APOE4 for the purposes of this program. And the most common of these is APOE3, and APOE4 is the one we're going to be talking about today. APOE4 is present in about 25% of individuals, and about 2 to 3% of people in the United States are homozygous for this, meaning they carry two copies of it. So it's a fairly common gene to have one copy of, to be a heterozygote. Homozygosity is infrequent, but not terribly so. So there's structural differences between these different APOE isoforms that affect their ability to transport lipids, to interact with amyloid beta, and to affect other aspects of Alzheimer's disease pathophysiology. And in general, it's safe to say that the E3 allele is considered neutral. It's the most common allele, so we sort of consider that to be risk neutral, whereas APOE2 seems to have a protective effect on Alzheimer's disease risk, whereas APOE4 has a disease enhancing effect. So it actually increases your risk of having disease. Somewhere around threefold if you have one copy of APOE4, and 9 to 15, even higher than 15-fold if you're a homozygote, depending on your ethnicity, which we'll talk about later. So how does this happen? Well, APOE has a lot of functions in the brain, and one of its functions is it interacts with amyloid beta and impacts the clearance of amyloid beta from the brain. Obviously, when amyloid beta accumulates in the brain, it can aggregate into plaques, and we think that's an initiating component of Alzheimer's disease cascade. And APOE plays an important role in that. So APOE can bind directly to amyloid beta, and it can help shepherd amyloid beta to clearance receptors like LRP1 or LDLR. APOE can also interact with those receptors directly and maybe compete for LRP1 with A-beta. In general, APOE4 tends to reduce the clearance of A-beta, both the cellular clearance and the perivascular clearance. So A-beta can be cleared not only by degradation by cells like glial cells, but also cleared in sort of bulk fluid flow from the brain via perivascular drainage, crossing the blood-brain barrier into the blood, or by glymphatic clearance, which is a fluid system in the brain. And in all cases, it seems as though APOE seems to negatively affect the clearance of A beta and promote A beta aggregation in the brain. APOE may even interact directly with A beta to cause its aggregation. APOE4 not only promotes aggregation of plaques in the parenchyma of the brain, but it also seems to enhance aggregation of amyloid beta in the blood vessels. So this is called cerebral amyloid angiopathy, or CAA. Being an APOE4 carrier is a risk factor for CAA and for Alzheimer's disease. And this is a topic we'll talk about a lot, that patients who carry APOE4 tend to have more cerebral amyloid angiopathy. And when they're treated with anti-amyloid antibodies, that puts them at higher risk for side effects. So APOE4 is a strong driver of both A beta deposition and Alzheimer's disease risk for sporadic Alzheimer's disease. It's by far the largest genetic risk factor for sporadic Alzheimer's disease. And as I mentioned before, of course, you have two copies of the APOE gene, one from mother and one from father. And so people who are APOE3/3, they're APOE3 homozygotes, they're the most common. It's the most common genotype in the United States. And we just have arbitrarily determined that in terms of risk, we're going to call that 1. That's neutral. So if you're APOE3/3, you're neutral. And you'll notice from this that APOE2/2, so people that carry APOE2, they're homozygous, who are very rare in the population, have a lower risk. Their odds ratio for Alzheimer's disease development is only about half that of E3/3 carriers. So APOE2 seems to be a protective variant, unfortunately relatively uncommon in the population. And as you can see, we'll highlight some of these numbers that are of importance. If you carry a copy of APOE4, it increases your risk of Alzheimer's disease. So people with one copy of APOE4 and an APOE3, a 3/4 genotype, have about a 3.5-fold increased risk. And as I'll show you, that can vary on several factors. And if you have two copies of APOE4, your risk is very high, 14.49% or fold, so 14 times higher than APOE3 carriers. And that actually can be even higher in certain ethnic groups. So APOE4 is, a major genetic risk factor for Alzheimer's disease. So as I mentioned before, there is a racial and ethnic interaction with APOE in terms of AD risk. So I'll draw your attention to the y-axis here. It's actually a logarithmic axis. So small changes mean a lot. So you can see if we look at our non-Hispanic white population, if you're an APOE4 homozygote, your risk, increased risk is about 14-fold, about 14 times higher than the reference, which is APOE3/3. But if you're East Asian, that number is closer to 25 times higher. So it's extremely high risk factor in people of East Asian descent. Whereas if you are Hispanic, that number is closer to 3. So it actually has less impact. And you can see in Black populations, it's about 5 to 6-fold increase. So your race and ethnicity has an impact. APOE4/4 is always bad. It always increases your risk, but it may have more impact in certain groups of people based on the rest of their genetics. Sharon, is this in keeping with what you see in your practice?
Well, yes, we don't generally order APOE4 genotyping in the clinical practice, but obviously as part of treatment with amyloid-targeting therapies, we're doing this a lot more. And so recognizing the prevalence based on race and ethnicity and that risk is something that we definitely talk about in the clinical setting.
So APOE4 influences the onset and progression of the disease as well. So you can see these are sort of survival curves showing the cumulative incidence of Alzheimer's disease dementia in these patients. And the patients who are homozygous for APOE4, this purple line, are developing disease earlier. You can see even by 80 years old, about 30%, 40%. So they're more likely to get the disease, and they get it at a younger age than the other groups. And again, you can see the APOE2 alleles having this protective effect. It's worth noting that APOE3 carriers get Alzheimer's disease. About half of all patients are APOE3 and carriers. So it's not that you can't get Alzheimer's disease if you have APOE3. It's just that APOE4 accelerates your risk and increases your risk. So what are the implications of APOE for amyloid-targeted therapies? That's going to be a major focus of what we talk about today. So let's first talk about the amyloid-targeting therapies, or the ATTs. These are the first FDA-approved disease-modifying drugs for Alzheimer's disease. Started with aducanumab back in 2021, was the first that received FDA approval. It received only accelerated approval, never was fully approved. And then it was followed by lecanemab. In 2023, summer of 2023, lecanemab received full approval from the FDA and was covered by Medicare. It actually really became clinically pretty widely used. And then actually aducanumab sort of never really achieved that, and it was discontinued, and lecanemab sort of took over from there. And then donanemab was approved by the FDA in July of 2024, just almost a year after lecanemab, and is now also in clinical use, also covered by Medicare. So we now have two ATTs in clinical practice that we use regularly. And one of the major risk factors, which I'm sure everyone is aware of, is with these drugs, is this phenomenon called ARIA, or amyloid-related imaging abnormality. This is an imaging abnormality seen on MRI, which is characterized either by edema. So there's ARIA-E, which is ARIA with edema, or effusion, which is, we can see here in the left panel, which is apparent on FLAIR or T2 images. And then there's ARIA-H, which are hemorrhages, microhemorrhages usually. So you can see this is an SWI or GRE image over to the right, showing multiple microhemorrhages that have occurred in this patient. Typically, the vast majority of these cases are asymptomatic. More than 90% of them are asymptomatic, but they do occur with some regularity when in patients treated with these, anywhere from 15 to 50% of patients, depending on clinical factors that are treated with these drugs. So ARIA is something that we really take seriously when we treat people with these drugs, and it's a major concern of ours. And one of the major risk factors for ARIA is APOE4 carriership. So we'll discuss that a little bit more. So there's a lot on this slide, but essentially I would direct your attention to the bolded ARIA-E and ARIA-H rates. This is from donanemab and lecanemab phase 3 clinical trials, showing you that in patients treated with lecanemab, there was about a 17% of those patients developed ARIA-H of some kind, and about 12% developed ARIA-E. Now, it's worth noting that ARIA can occur in the absence of treatment with antibodies. So anyone with Alzheimer's disease can get cerebral amyloid angiopathy. They can get microhemorrhages. They can get ARIA-E or ARIA-H, more commonly ARIA-H. But the anti-amyloid antibodies increase the risk of this. As you can see here, it goes from 9 to 17%. But you can notice in the APOE4 homozygotes, that number's 38%. So, and you'll notice actually, even without treatment, about 20% of the APOE4 homozygotes have ARIA-H at baseline. And the numbers are even higher in the original donanemab trial, where they had about 30% of the patients had ARIA-H and 24 of them with ARIA-E. Again, it's worth noting that the placebo group had 13.6 had ARIA-H. And that number goes up to 50% in the APOE4 homozygotes. Now, it should be noted that with donanemab, introduced an altered dosing regimen in which the dose is escalated slightly more slowly, and this seems to reduce the ARIA rate of donanemab closer to that of lecanemab. So the numbers are smaller. There's about 200 people per group in this one, but you can see that now we're down with the modified titration, about 15% of people getting ARIA-E and maybe 25% giving ARIA-H, although we don't have a full breakdown by APOE genotype yet. However, we do for ARIA-E, and it looks as though there is still a reduction in the APOE4 homozygotes with this altered titration. So that's something to take into account with these medications. So the treatment implications for APOE4, is that the risk of ARIA in patients who are receiving anti-amyloid therapies is related to APOE4 genotype in a dose-dependent manner. So 1 copy of APOE4 increases your risk slightly. 2 copies of APOE4 has more significant impact on risk. And so APOE4 carrier status may modify the treatment response. And when you look at the clinical trials in a pooled manner, that there is some signal that suggests that the antibodies may also work better in patients who have APOE4. They have more amyloid, and that perhaps there's greater efficacy. So, we could have an interesting conundrum where you have patients who are at higher risk, but they also may have higher reward from the drug. And so we really need to address informed discussion with patients and their care partners about how to do APOE genotype testing and what it means. And in general, APOE4 carriers, especially homozygotes, they have a higher risk of ARIA. They may choose to accept that higher risk, and that's a discussion that requires a careful hand. Dr. Shaw, do you think, in your experience, that homozygous people for APOE4 are more motivated to get treatment, or do you think they're more afraid, or what do you think?
Yeah, I don't think in my clinical practice that homozygotes are necessarily more motivated. They understand the risk and then may be willing to undertake it. I might say that I've noticed that people who are younger are more willing to take the risk, and so that because of their younger age may predispose them to have an APOE4 1 or 2 copies. So I am noticing that there are some who are more motivated to get the amyloid targeting therapies.
Yeah, I agree. Well, I'm going to hand it over to Dr. Shaw for Module 2.
Thank you, Dr. Music, for a wonderful introduction. Now we're thinking about implementing the APOE4 and APOE genotyping as a whole in the clinical practice setting. And we're thinking about shared decision making. Now, we don't need to go through all the inclusion and exclusions for the requirements for lecanemab and donanemab, but it's important to note that the appropriate use recommendations for getting these therapies are requiring that we're getting the APOE genotyping prior to starting the amyloid targeting therapies. And so it's really thinking about understanding that risk and having that discussion with patients and families, and really thinking about that dose gene effect to the ARIA risk. And we do want to make sure that we're discussing and exercising caution with those that have 2 copies through the risk benefit that are appropriate for that discussion. When we think about the APOE genotyping in sort of the workflow of going through the process of understanding whether a patient is appropriate for these therapies, we often start off with a basic workup, the cognitive assessment, MRI testing, understanding whether they're appropriate or not, and then moving forward, oftentimes in a stepwise fashion. And generally, patients do know their biomarker status before we move on to getting their APOE genotyping. And then we start thinking about the counseling and the appropriate discussion as part of this therapy. Dr. Music, is this the way that works for you in your clinic?
Yeah, we do things in a similar way. And in general, we aren't talking to patients about their APOE genetics until we already know that they have amyloid in their brain, which helps kind of defray some of the ethical concerns.
And there's some that may refer to geneticists or genetic counselors as part of this process. Is that something that you do in your clinic also?
We do, particularly when there's family concern, in special cases. I wouldn't say that we refer the majority of patients. I think patients can understand this information probably without genetic counseling for the most part. But if there's kind of unusual circumstances or family members that are maybe concerned about learning their own genetic status, then certainly we take that route.
I think that's very helpful. Thank you. And I think as we go through this process, it's really key to think about all of the multidisciplinary care that's involved in counseling and treating and continuing the workflow, not only when we're determining whether a patient is appropriate for the therapy, but as we continue to administer the therapy and monitor for their safety. So the APOE4 genotyping and just the testing in general is part of the process. And we've just talked about genetic counselors as part of that process, particularly if you have access to one. But we have not only the neurologists and advanced care practitioners that are involved, but we're thinking about nurses, care navigators if you have them, social workers if you have them, and really including the patient and families in the discussion throughout the process and as we continue with therapies. Because if someone develops ARIA, for example, we want to have continued discussions about risk benefit. In your clinical practice, Dr. Music, who would you say are people that you really lean upon in terms of this process?
I think in our center, the advanced practice clinicians do a lot of this, and they do a great job with it. They're sort of the first line of defense, and they do a nice job of explaining the risk. And then if there's need, then we'll go to genetic counselors from there.
That's fantastic. I think we lean a lot on our nurses to help organize us and compile all the information, including the biomarker status, what tests, and where they are in the process. And as we think about the genetic counseling and education, there's some key components that we often think about. And I would say, really, before we do any test, including genetic testing, it's important to counsel the patients and families about what we're doing. First, what are we trying to determine from this? A lot of patients and families think that the APOE genotyping, it has something to do with the diagnosis of Alzheimer's disease. And oftentimes what we're seeing is that we're getting the biomarkers already, so the diagnosis of Alzheimer's disease should already be present. But we're understanding the risk for ARIA. So really discussing with the patients and family the consent process. What are we testing for? Understanding the rationale, education of the value of this testing. Again, not because of that it's diagnostic, but to really help determine ARIA risk. And then that APOE genotyping also helps determine risk for developing Alzheimer's disease. And that any of this test result may have implications for family members of the patient, specifically the children and siblings, and understanding what that might entail. And then finally, thinking about insurance coverage of the testing. And so going forward, patients and families have their eyes wide open for what the test involves, what we're testing for, so that when you do the post-test counseling, we can understand what that disclosure means and what those benefits of what those genotyping means. And we really then can understand with the patients and family their reaction as we prepared them through that process. We want to make sure that we do include understanding of family members, because many family members may have recognition of what this might mean for themselves, and really thinking about what this might mean for their future as they learn the result, because this may affect their emotional well-being, their lifestyle choices, future planning, and even insurance decisions. When we think about this, we should assess whether patients, their care partners, or other family members are distressed about the test result, and then consider referring to genetic counseling or mental health services as needed. A lot of times, learning this information may weigh heavy on them, and having those resources may be particularly beneficial in understanding what that means. The schematic here may be helpful for them understanding, particularly this is a demonstration of someone in the blue there that has 2 copies of APOE4. And if you assume that that red line is the APOE4 and they have 2 copies, they got one from mom, they got one from dad, and what that relevance may mean for the children that they have and siblings that they may have. So the schematic can be helpful in understanding their own inheritance and then how this may pass on to other family members. It's also important to note that genetic information may have implications for discrimination and other types of insurance. Now, we do have laws that protect against genetic discrimination, and this was related to the Genetic Information Non-Discrimination Act in 2008. And that's a federal law that protects pre-symptomatic individuals who are at risk of a disease based on their genetic profiles against discrimination for health insurance and employment. And that's specific to health insurance and employment. But this protection may be limited related to people who already have the clinical diagnosis and are cognitively impaired. And it does not protect against life insurance, disability insurance, long-term care insurance. And so this could potentially impact the ability of asymptomatic children to get these types of insurances. So it's important to think about before we do the testing. A lot of times we can get our ducks in a row, so to speak, before we do that testing and understand. And some states have laws that provide additional protections, so learning what may be available in your state can be very helpful. And the information on U.S. state laws can be found through the National Conference of State Legislatures. And so in the healthcare settings, there may be two types of tests that we can get. The APOE genotype testing, which uses whole blood, and you get the APOE 2, 3, 4 genotyping, understanding that. You can also get an APOE proteotype test, which includes CSF or a blood sample. And again, you get an understanding about the APOE isoforms of 2, 3, and 4. And there are different methodologies between this. Now, when we look at the different types of tests that can be done, there are a lot that are available. So understanding what may be easier to use for your site and your clinic and the different costs available and insurance coverage may be appropriate as you think about which test to order and from which company. Now, there are direct-to-consumer genetic testing. So these are home PCR cheek swabs that can often be less expensive than the blood or spinal fluid testing and may be an option for some patients, but there are some certain factors that we do need to think about. So some of these tests may not be FDA approved, so we may have some concerns about the result integrity and potentially even repeating the test. And then oftentimes these tests don't have the pre-counseling that we said was just so important and understanding what that means. I've had that experience in my own clinic where people had the direct-to-consumer and then didn't understand what that meant and thought that they were destined to have Alzheimer's disease based on those genetic results. Dr. Music, what has been your experience with the direct-to-consumer testing?
I use it to some degree, particularly for patients who don't have access to the other testing or don't have the money for it necessarily. Often, the APOE tests are not covered by insurance in my experience. And so these are often less expensive. But I think, I always choose one that is a CLIA certified lab. And I think what you're saying is right. I mean, I generally pre-counsel my own patients before they take the test so they know what to expect and explain the result to them. There's not that many potential results, so it doesn't take that long to explain, what it means. But in terms of the actual mechanics, it's quite easy, actually. The patients have been able to get it. It's back in about a week and, relatively inexpensive. So I do think it's an option for some cases.
That's helpful to know. Thank you so much. And so coverage may be different for the APOE testing also. So many commercial companies now or insurance companies now cover the testing for the risk stratification in preparation for amyloid-targeting therapies. Medicare Advantage plans are likely to cover the APOE testing, but because coverage can vary, it's important for us to recognize and for patients to understand also with their specific plan what may or may not be covered. Has this been your experience also, Dr. Music?
Yeah, I think so. I mean, it's an ever-changing landscape. So it seems like, each week it seems to change. But in general, I think it's moving towards these companies covering things and Medicare covering it. But like you said, likely is not certain. So it can be a little hard to know sometimes.
And for us, where we practice, it's been when we first started, the APOE coverage was the biggest holdup. And now it's not so much. So I think things can change over time.
Yeah, I think they're changing for the better in general.
Yeah, it's fantastic. So let's discuss a case of Janice. She is a 72-year-old retired high school teacher with mild cognitive impairment due to Alzheimer's disease. Her mini mental status examination score is 25 out of 30, and her amyloid PET was positive. She has overall good health. Her older brother was recently diagnosed with dementia at 75. His APOE status is unknown because he was diagnosed too late for treatment with the amyloid-targeting therapies. The care partner of Janice is her daughter, Teresa. On MRI, she has diffuse atrophy. It's mild to moderate in the parietal lobes, minimal frontal, mild in the hippocampus, and then some mild to moderate small vessel ischemic disease with 2 microhemorrhages. Janice is highly motivated to start treatment with an amyloid targeting therapy because she just does not want to end up like her brother, who has advanced dementia. Teresa, her daughter, says that she's concerned that genetic testing on her mother might reveal something about her own risk for Alzheimer's disease. Some key points that we should make sure we talk about with Janice and her daughter, again, as we said earlier, is the rationale for the APOE testing in this specific situation. That's really for the ARIA risk. However, we have some concerns based on Teresa's own risk in that discussion. As we just mentioned, Medicare coverage or insurance coverage for the APOE testing is important to discuss. And finally, what results may reveal about not only Janice, but Teresa's genetic risk. We may consider referring her daughter, so Teresa, to a genetic counselor if she has more questions about her own risk. And then I think also that we may often miss in discussing is if, say, Teresa doesn't want to know her own risk, we should confirm with her about being present when we discuss the results, because that may inadvertently let her know her own risk. Dr. Music, any other points that you wanted to mention related to this?
Well, it can get kind of tricky because ultimately, if Teresa is going to help Janice make a decision about whether or not to be treated, she'll sort of have to know this information. So ultimately, I think Teresa will have to decide if she wants to be the care partner or not, or find out. I don't know that you can have it both ways. You're probably going to find out if you're the care partner. So it is possible to make these decisions. I mean, you could potentially just say, I don't care what my APOE status is and I want to be treated, but it's not ideal from the clinician's standpoint at all. I think if Teresa really understands what this is going to tell her, even if we have this information about Janice, it doesn't necessarily, we don't know Teresa's genotype. All we would know is potentially one of the alleles, only if Janice is a homozygote. So at worst, Teresa is going to find out that she carries one copy of APOE4. We don't know what the other one is. So, perhaps that would help. But in general, I think if you have someone that really doesn't want to know, then they have to decide if they're going to be the care partner or not, or it makes it really difficult.
Exactly. I think if she does want to be the care partner, we would want to include her in the discussion about ARIA and the specifics that we know about her. And then I guess the other point is to remind her, especially with the counseling, reminding Teresa that the APOE genotyping is not conferring a diagnosis. It's really about risk. And so some communication strategies when we disclose the APOE test results to patients are sort of, it's sort of without saying that we do want to be as clear as possible using the plain language. Oftentimes the visual aids like the schematic that we showed earlier can be really helpful, and any other visual or educational materials maybe that be helpful during the time of the disclosure, or even materials that the patients and families can access later so they can digest the information in their own time. Probably avoiding too much information can be a little bit easier to digest again. That less is more can be more valuable. And giving time for patients and families to ask questions, discuss any concerns that they have after learning that, and really trying to assess their emotional response to those results. Oftentimes, though, if they already know their diagnosis, then maybe there may not be the same sort of emotional response to this. And then when we're giving the post-disclosure genetic information and counseling, we really want to make it clear this is to inform about treatment decisions with people who have early Alzheimer's disease. So again, patients should already know their biomarker status as they've gone through the process for testing for Alzheimer's disease, the amyloid status, to really determine that they have AD pathology as part of the amyloid targeting therapy process and determining whether they qualify. So the APOE genotyping is more about risk stratification for ARIA. And then when we go over the APOE genotyping results, then it's in the context and the risk for ARIA. So we know that both symptomatic and asymptomatic ARIA risk is increased in APOE4 carriers, and it's a gene dose effect such that the homozygotes have the most risk and the non-carriers have the least risk. And we want to make sure that knowing these results usually does not affect the amyloid targeting eligibility or dosing. And I say usually because there are some centers that don't treat APOE4 homozygotes, but a lot of centers do. And it really, the genotyping does not affect the dosing and does not affect the monitoring, actually. We want to make sure we share with patients and care partners the need to follow and stick to the monitoring guidelines that are set forth for them as we initiate and continue the treatment. And this is not to memorize, but to give you an overview of the MRI monitoring for lecanemab and for donanemab. So it's set, and it's set for whatever APOE genotype the patient has. So that's important to note, that we don't change the MRI monitoring based on that, that they're set schedules. And we do this at baseline and these recommended intervals, and then we may add an additional MRI in case there's symptoms related to possible ARIA. And these symptoms can be very nonspecific. So headache, seizures, dizziness, nausea, vomiting, fatigue, blurred vision. I don't need to read all of them, but they can be very nonspecific. And with these symptoms, this could mean that someone has ARIA. So that would trigger an out-of-sequence MRI, an additional MRI. So, and we can think about the symptom severity with mild, so maybe no disruption of daily activity, versus moderate or severe, and that might trigger additional sort of urgency for MRI and maybe even ER visits. With shared decision-making, obviously it's important to include the patient and family and care partners, understanding their goals. What I've seen in my clinical practice also is that sometimes patients and their families may have differences in opinions. So really getting aligned with the family and patient and the provider about what the goals are, what the needs are, what the expectations are, and really discussing some of the uncertainties. So potentially costs that are appropriate, the risks of the therapies, the support that may be required, and making sure the patients and family have that informed choice and an informed consent, understanding the risks, benefits, and alternatives. Now, we have our patients and families sign a consent form with our therapy so that we can document and make sure that we're clear about all of the discussions that we've had with these patients. Is that something you might do in your practice, Dr. Music?
Yes, we do the same thing. It's sort of a checklist that we've gone over all these points, and it helps just clarify that they understand them. But I mean, I think these issues that you bring up, you never know which of them is going to resonate with patients. Sometimes it's the cost, sometimes it's the inconvenience, something, it's not the risk necessarily of ARIA every time. Sometimes it's a combination, all of the above. If they live far away and they're taking care of an elderly parent, it may just be impossible to do. So I think to make sure they understand the whole picture, not just ARIA risk, is important.
And I think that's a perfect segue to this next slide, where when we discuss with patients and families, not only discuss the expectation of what the drug does, I think a lot of times not having the discussion, patients and families think that this medication is to improve symptoms or even cure them. So we manage those expectations that these medications are disease modifying and may slow progression, and really discussing the risks of ARIA as we've talked about. But what you said about the commitment, right? The burden. So if someone lives far, what does that mean for them? Is this worthwhile to them in terms of the burden of the frequent visits to the clinic and infusion center, plus the additional MRIs? And the burden may also be cost. So if insurance isn't fully covering this, or some of the burden for the travel, what does that really mean for the patients and families? And then really discussing what the alternatives to these therapies are. So they may feel like it's all or none, but there are lifestyle modifications, there are current oral therapies that are available, and really thinking about even research and other opportunities. Dr. Music, is there anything else that you would make sure that we would include in these shared decision-making conversations?
Well, I mean, I definitely emphasize the lifestyle modifications for some patients. So probably in California, I have fewer of these people, but we have a lot of patients who are snowbirds, who travel for the winter. Um, and they may not be able to do that. That may be the thing they love the most is to go to, Phoenix for the winter and play golf. And they may not be able to do that if they're, getting infusions every 2 weeks. So, that's something to consider. I think also you made a good point about, what are the alternatives? I do think sometimes it's worth mentioning, or at least, that the alternative is not always good. I think sometimes patients say, oh, I don't want to take, a 7% chance of having a negative side effect. It's like, well, this is a deadly disease, so the alternative of doing nothing is, that the disease progresses, and it's not always a pretty picture. So I think most patients understand that, but some of them get a little caught up in, oh, I have this, it's inconvenient or whatever. But I think, they need to understand both sides of it, that if they choose not to do the therapy, that, they're looking at, a very difficult road, either way, really.
And I think a similar point is sort of the decision is a big one because of all of the factors we talked about, but it isn't all or none and then it's go forever. A lot of times we can take a pause, take a look, and if something happens or if there's a side effect, we continue to have that discussion of the risk benefit with the patient and family. Is there ongoing burden? Or they're feeling good, let's keep going. There are times that we can continue to have the shared decision making. Well, now getting back to Janice, our 72-year-old retired high school teacher, her APOE genotyping came back and she's an APOE4 homozygote. So what does this mean for her? Well, then we would have a more specific discussion about her risk for ARIA. So because she has 2 copies, she has the greater risk of developing ARIA, and making sure that we share this information with her. And if she has 2 microhemorrhages, as the original discussion mentioned, she has that added risk. If she has 4 microhemorrhages, this may be even greater risk, and maybe even some centers may not prescribe the amyloid-targeting therapies for her. We want to make sure we educate Janice and Teresa about monitoring for ARIA, and then revisit how these results may impact Teresa's lifetime risk for Alzheimer's disease. Anything else, Dr. Music, that we should make sure we discuss?
No, this is, the worst case scenario for Teresa, probably, that we know she's now a carrier. But for her to understand that we don't know her other allele, and I think this might be an instance where it would be worth talking to a genetic counselor, but does she want to, get tested herself, and what the implications of that would be?
Yeah, and I think if she has 4 microhemorrhages instead of 2, we still counsel her. I don't think
Good.
we wouldn't change, dosing, as we said earlier. We wouldn't change MRI monitoring, but it is added risk.
Yeah, the criteria are the same. I think that's an important point. And this doesn't really change anything in terms of the criteria, but it might give pause. Some, clinicians may say, oh, if there's any microhemorrhages in their E44, I'm not doing it.
Right.
Unfortunately, people who are E44 are also likely to have microhemorrhages, as we saw in the previous data. So
It's true. So, Dr. Music, I think this is on you to read to us.
Sure. So let's talk about Wilfred, a 67-year-old librarian with MCI due to AD, a mini mental status of 23 out of 30, CSF amyloid positive. The story with Wilfred is that he has factor V Leiden mutation. So he's hypercoagulable, and he had a DVT last year that was treated with a Pixaben anticoagulation. He's not currently on anticoagulation, and he has a sister that had MCI and AD in her 70s. His MRI is sort of typical MCI MRI. So he's very eager to start these anti-amyloid therapies. And as soon as he found out his sister had AD, he ordered a direct-to-consumer cheek swab APOE test and found he was a 3/4 heterozygote. So, is he a good candidate for ATTs? Why or why not? Well, he's at high risk for developing ARIA because he carries 1 copy of of APOE4. So he's at not super high risk, but elevated risk compared to E33s. And potentially because of this factor V Leiden, although we don't have great data on how a thrombophilia like factor V Leiden affects ARIA rates, actually. So, but I think more importantly, there's this risk that he will get another DVT, and then he'll have to be anticoagulated after he's been treated with anti-amyloid antibodies, either during the treatment or afterwards. And so that's a consideration, and so that's something that I think he would need to discuss with his hematologist to see what is the risk of that. We don't really know, years after someone's been treated with anti-amyloid immunotherapy, if they develop some microhemorrhages, are they at higher risk of hemorrhage later if they're anticoagulated? We don't know that entirely. So this is a risk that you'd have to definitely do some shared decision making with Wilfred to figure out his appetite for risk. It's certainly not a bread and butter case, one that you'd probably want to discuss, at your consensus monthly meeting or weekly meeting. We have a monthly meeting. You probably have something more frequent, but to get other people's opinions about exactly how to manage this. What do you think?
Yeah, I wouldn't say he's a great candidate, mainly because of his potential for needing to be on anticoagulation. And so I bet in our consensus meeting, there would be split faculty votes here, because we don't treat people who require anticoagulation. And for whatever reason, those who come off of it or stop it, when the risk for having a thrombus continues, we get very concerned about, and I would say that we're a little more conservative. We get more concerned about what that risk might be in terms of being on the amyloid-targeting therapy and starting anticoagulation. So if the risk for Wilfred is high to need to be on an anticoagulant in the future, then we might think about not prescribing it. Though if his hematologist says, hey, the risk is pretty minimal, we don't really know, and Wilfred probably is really motivated, right? He did this direct-to-consumer testing. Some of us may be swayed. So it's definitely having that discussion with Wilfred and his family, and what our experts on our team and panel may suggest.
Yeah, I think anticoagulation is a tough topic because there isn't a lot of data actually showing that anticoagulation increases risk. It's more anecdotal that the really bad outcomes have been some of them in patients on anticoagulation, and those carry a lot of weight. So, if you look at the data from the lecanemab trial, it really doesn't show any increased signal for ARIA in patients who are on anticoagulation. In fact, the numbers are a little bit lower in that group, but obviously you don't want to have catastrophic intracerebral hemorrhage either. So, and if this is kind of a long-term, he's a relatively young guy. If he gets treated now for 18 months with an anti-amyloid antibody, develops a bunch of microhemorrhages, and then gets a DVT 2 years from now, I'm not sure how you manage that exactly. It could be, if he has to be on a long-term anticoagulation, his risk of intracerebral hemorrhage is really unknown. So,
Right.
It's a tough one. It would be probably a more aggressive group. Our group might treat this guy, but many would shy away, I think, a bit. So what would happen if Wilfred was an E4 homozygote? So I think we've already kind of said that he's kind of a very risky candidate to begin with, and this would just increase the risk, I think, beyond what most people would be comfortable with. Certainly, I think most people at our center would be uncomfortable treating a homozygote with a thrombophilia who's likely to need anticoagulation. And I think it's a good example of why you need APOE genotyping to make these kind of decisions, because, sometimes these risk factors kind of add up. You might be willing to treat a homozygote, but not a homozygote with a factor V Leiden, or not a homozygote on anticoagulation, or, something like that. So that's my take on it. I don't know how you feel about it.
Yeah, I think that sort of quantitative adding of different risks that in isolation may not be enough, but when we have a few different factors, that might push us over the edge to say, I'm not sure this is safe for you. Obviously, we want to do the best for your care, but we also want to do no harm. And we think the harm may be of greater risk or potential here. So,
And I think this is a great question. Where would you draw the line? Because
yeah.
I think more frequently we run into patients who want to be very aggressive,
Mhm.
and it's very difficult, I think, for them to fully understand like what the risks are, when it's your own. And their argument would be, I don't want to get Alzheimer's disease. If I
Yeah.
die from a stroke, I die from, it's hard to argue with that. But at the same time, I feel like there has to be a point where you say, no, this just isn't safe.
Mhm.
The benefits are greatly outweighed by the risks in this case. And, um, but that can be tough if you have, a very motivated patient who's, who's clearly doesn't care, or at least thinks they don't care about the risk. It's easy to say that in the office when you're, not staring into the face of a large intracerebral hemorrhage, which is a different scenario. So I don't know, where do you draw the line with a patient like that? If they really wanted this and they said they didn't care, they'd sign any paperwork, do anything they could, you know.
That's a tough one, and I would say that's why we have that consensus meeting,
Mhm.
so that it isn't a lot of times we wanna do the best for our patients, and we care about them, right? So the one-on-one sort of face-to-face discussion of, I don't think it's safe, but they're desperate, where that consensus meeting sort of says, "Our experts in the room all thought about you carefully, and we did not think it was safe for you, and that risk was too great, and so we wouldn't give that to you." And I think that helps us at our center make things a little bit easier for that sort of desperation where we just don't think it's as safe.
Yeah, that is good, and it sort of also helps maintain the doctor-patient relationship a
Mhm.
bit if you can defer some of that decision,
Right.
"Well, the expert said no." I think also under the patient needs to understand this isn't gonna cure them, you know? If this was a drug that cured Alzheimer's disease, it would be maybe a different conversation. You might be willing to really, take a lot of risk in that kind of case, but if it's gonna slow things by 30%, that might not be enough to merit
And that's
this.
maybe where we really, hone in on some of the lifestyle measures, discuss any potential research options. All of that can really then be brought up as there are ways for you to have some autonomy. Let's give you some of these other options.
So the key takeaways from our conversation today are that APOE is a genetic risk factor influencing AD risk. I think we went over that in some detail. And that ARIA is more common and more likely in APOE4 carriers, and particularly APOE4 homozygotes who are at very high risk. However, in many centers, and including ours, APOE4 homozygosity is not a contraindication, and certainly APOE4 carriership is not a contraindication to treatment. Um, and that in all patients, regardless of their APOE4 carriership, you have to be vigilant for signs of ARIA. There's no different treatment regimen for patients with APOE4, but it's something that is built in and baked into the discussion of risk, so that the patients and their families can really understand how their APOE genotype impacts their risk of ARIA, and make a decision that they're comfortable with and that you are all comfortable with. So thanks for joining us today. I hope that you've learned something about APOE genotyping. Sharon, thank you so much.
So great to be here. So much great information.
Thanks again.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/JNT860.